Hi all, let's start with the topic approach to myopathy. You need to have a knowledge of basic anatomy here. So this is a muscle. The muscle is made up of small muscular fibers. The muscle fiber is innervated by the nerve root. At the end of the nerve root, the axonal terminal forms a neuromuscular junction with the muscular fiber. All right. So a motor. This is the motor unit. A neuron that is innervating the muscular fiber forms a motor unit. So there can be two motor units. One is the afferent one and the other one is efferent one. So where all can the problem go wrong in the body? So the problem in case of myopathy can be at the level of the muscular fiber only. It can be at the level of neuromuscular junctions here. It can be at the level of motor neurons that are coming in innervating the muscles, or it could be at the level of the cell body that is present in the spinal cord here. So, what is a motor unit? Motor unit is the one anterior horn cell, motor neuron, and all the skeletal muscle fiber it innervates through the neuromuscular junction. So, this nerve that is coming, and this is the neuron it is sending, and you can see this neuron is innervating the multiple muscular fibers here. All right. So, this forms one motor unit. Similarly, this neuron is innervating other muscular fibers, and this forms the other motor unit. So a motor unit consists of a skeletal muscle fiber and a motor neuron that is innervating the muscular fiber. So a group of motor units often work together to coordinate the contraction of a single muscle. A motor unit is influenced by upper motor neuron that controls and alter the property of the muscle tone. So the upper motor neuron is here. So they send the signal and that causes the contraction of the muscle fiber. So, neuromuscular disorder can be a disease of the motor unit. So, if it happens in the anterior horn cell, it will be known as the neuronopathy. If it happens at the level of anterior horn cell axon or myelin, then it will be a neuropathy. If it happens at the level of neuromuscular junction, it will be a neuromuscular junction disorder. If it happens at the level of muscle, it will be called as a myopathy. The presenting complaint could be weakness and floppiness that we need to differentiate on further approach. So let's start with the types. All right, the lesions, I have told you, the lesions could be central here. This is a central lesion, or the brain also. The spinal cord of the brain comes in central causes. The lesion can be at the level of anterior horn cell here. The lesion can be at the level of the peripheral nerve, or the lesion can be at the level of neuromuscular junction, which I have already showed in a muscle. So these are the possible defects that can happen. Now, what is a striking feature you should be remembering about all? In central diseases, the hypotonia, the weakness will be more proximal or compared to distal, but it can be equal also. Similarly, anterior horn cells can have proximal weakness compared to distal. There is important importance of DTR, deep tendon reflex, will be absent, and there will be fasciculation that you should not miss. There will be fasciculation. If there is fasciculation, we are talking about anterior horn cell defect. So if you go for the muscle biopsy in case of anterior horn cell defect, you will find denervation pattern. Example is SMA. In peripheral nerve defect, the DTRs will be decreased. There can be sensory deficits also with muscular atrophy. Denervation pattern is also seen, and hereditary muscular sensory neuropathy then is one of the example of the peripheral nerve defects. Neuromuscular disorders, it will be proximal and distally both are affected. There'll be a normal DTR, there'll be fatigability, waxing and waning course with ptosis. The muscle biopsy will be essentially normal. The example is myasthenia. In muscular defect, there'll be more of proximal weakness compared to distal. The DTRs will be absent. You can find elevated enzymes with progressive muscle weakness and a proportionate atrophy. The muscle biopsy, if you do, you'll find myopathic pattern. So a structure of the muscle. So we know a muscle is made up of a muscle fiber, bone. This is the bone. Then there is a tendon that is attached to it, which connects the muscle to the bone. Then with the extension, we have small myofibrils, multiple small myofibrils, which forms the muscle fiber. Muscle fiber is coated in a sheath called endomysium, and the whole unit is known as a fascicle. The muscle is surrounded by epimysium, and in between we have the perimysium. The structure of sarcolemma, well, these are the protein that is essential for the structural stability of a muscle fiber. I won't be going into the detail because that will become very complicated. You should be knowing just the names like dystrophin, syncolin, desmin, dystroglycan, syntrophin, sacroglycan, sacrospan. You will be hearing some of them later on in the video. So, definition. So, what is a myopathy? Disorder involving the muscle. Congenital myopathy is non-progressive disease of the muscle due to morphological abnormalities in the muscle cell fiber and their distribution. Dystrophy, how it is different from myopathy? It is a progressive disease. Myopathy is non-progressive. Whatever illness you will see, that will be at the maximum. Whatever weakness you will see, that will be maximum. There won't be further progression. Whereas in case of dystrophies, there will be progressive deterioration in the muscle that is characterized by degeneration and death of muscle fiber due to abnormalities of the sarcolemmal proteins. Myositis is inflammation of the muscle, so it is mostly transient following a viral infections. So myopathy can be inherited or acquired. Classification of congenital myopathy. Congenital myopathy are the congenital fiber type disproportionate myopathy, central core myopathy, multiple core myopathy, or Nemelin rod myopathy. Muscular dystrophies can be congenital onset like congenital muscular dystrophy deficiency, merosin deficiency, or abnormal dystroglycans. Congenital myopathy can be channelopathies like periodic paralysis, myotonia congenita, metabolic myopathy like glycogen metabolism in like the Pompe's disease. It can be a mitochondrial myopathy like Kearns-Sayre's disease or MELAS, or it could be lipid metabolism like carnitine deficiency. Then the classification of acquired myopathy. It can be inflammatory or a dermatomyositis, polymyositis, endocrine myopathy, hypothyroidism, drug-induced myopathies due to corticosteroids. So the clinical features, what the parents presents as. If you have an infant, they will complain of a floppy infant, weak cry, poor feeding, decreased fetal movement, or motor developmental delay. But in case of older children, the parents will come with the complaints of abnormal gait, frequent fall, difficulty in getting up from floor, difficulty in climbing stairs, pain and muscle cramps. So what are the clinical features that you will see? So the negative complaint that you will see, that the patient will complain of weakness, fatigue, exercise intolerance, muscular atrophy. Positive complaints will be myalgia, cramps, contracture, myotonia, or myoglobinuria. So, clinical feature, the history of age of onset can give us a clue. So, myopathies presenting at infancies are congenital muscular dystrophy, congenital myopathy, myotonic dystrophies, Pompe's disease. Myopathies presenting child in Duchenne limb girdle. So the progression, if the progression is acute or subacute, we know we're talking about inflammatory myopathy, dermatomyositis, and polymyositis. If it is non-progressive weakness, we know it. We are talking about congenital myopathies. I've told you in the beginning. Chronic slow progression over years, we know we are talking about most muscular dystrophies. And episodic is seen in periodic paralysis, metabolic myopathies due to certain glycolytic pathway disorder. So family history is very important in your approach. You should be asking about the family history. You will be making a family tree of 3 generations because we want to know the pattern of inheritance that is seen. It is autosomal recessive, it is X-linked. What is it? We want to know to identify the cause. So in the birth history, you can ask the parents about history of consanguinity because that is very important. In the pattern of inheritance, autosomal recessive more predominantly seen when there is history of consanguinity. There will be decreased fetal movement. Mother can give a history of decreased fetal movement. There can be polyhydramnios because the baby swallows the amniotic fluid. So if there is a muscular weakness, there will be difficulty swallowing the amniotic fluid, and the mother can have polyhydramnios. There can be a breech presentation because of inadequate movement in the womb, and there can be weak cry at birth. There'll be feeding difficulty. There'll be respiratory distress with prolonged ventilatory support because their muscle does not have the power to sustain breathing, so they can have prolonged ventilatory support. Presence of hip dislocation and early contractures. So development history is very important in case of your approach to know exactly how much is the motor delay. If there is isolated motor delay, we know it favors neuromuscular disorders. However, delay in these domains can present in myopathies also, with associated CNS involvement like congenital muscular dystrophy. So you will be examining the baby, you will be noting out if there is tachypnea, there's tachycardia, there's respiratory distress or not. You will see the anthropometry to rule out failure to thrive, obesity. So a floppy infant is how it is to be examined. Like the baby will have this sort of ragdoll sort of appearance. The baby will be slipping through the hands. So there'll be complete head lag on when the baby is made prone, and we are when the baby is pulled to sit. There'll be complete head lag. There'll be this is we are demonstrating scarf sign, the side of the baby's elbow going towards the opposite side completely. So heliotropes rash, the clinical examination you can find heliotropic rashes, and this is Gotron's papule. It is seen in cases of dermatomyositis. Then you can find these congenital myotonic dystrophies, wherein you will see the muscular pattern of these babies, like there'll be Herculean appearance in case of myotonic dystrophies. There'll be calf hypertrophy. See, this is calf pseudo hypertrophy. So why do we say it's pseudo? Because it is not just the muscle that is hypertrophied. Here it is the hypertrophy is due to deposition of fat and overgrowth of the connective tissues. It's not just the muscle that is hypertrophied. So it's known as a pseudo hypertrophy. It is seen in the case of Duchenne's muscular dystrophies, right? Of pseudo, so what are the causes of pseudo hypertrophy? The important one is DMDs, Duchenne muscular disorders, sarcoglycanopathies, myotonia congenita, SMA type 2 and type 3. Now we'll be noticing the gait and the posture. If the gait is the waddling type gait, proximal myopathy like DMD is there. If the waddling gait with a lordotic posture, there's a hip girdle weakness. If there is Gover signs present, it's a proximal hip girdle weakness. Also check the spine for scoliosis. Neck flexor weakness is seen in DMDs. So I'll be coming up with the part 2 of this video. If you want that, please do leave a comment. Thank you so much.